Hi, good morning. So we're going to get started. Good morning. Today I'm excited to introduce our guest speaker, Dr. Icilma Fergus. Dr. Fergus completed her medical degree at SUNY Downstate and her internal medicine training at the Albert Einstein Medical Center, where she served as chief resident. She completed her cardiology fellowship at the Weill Cornell Medical Center. Dr. Fergus serves as a director of cardiovascular disparities at the Mount Sinai Hospital. Prior to this, she serves as chief of the Division of Cardiology at Columbia University Harlem Hospital Center and the director of non-invasive cardiology of New York Hospital Queens from 1999 to 2006. Her work focuses on areas related to preventative cardiology, including lipids and hypertension, women's heart disease, and cardiovascular health advocacy. She is a prominent educator in the Harlem community and is the founder and director of the series Healthy Hearts Projects, including Harlem Healthy Hearts. Dr. Fergus has authored numerous articles related to heart disease and congestive heart failure in peer-reviewed journals and is co-author of the book titled Cardiovascular Disease and Ethnic Minorities. She has been an investigator in several clinical trials, including the NHL-BI-sponsored trial evaluating acute ischemia in young women entitled Virgo, and the DOH-sponsored grant for the Harlem Health Equity, Eating and Living. Please join me in giving Dr. Fergus a warm welcome.
Good morning, everyone. Can you hear me? Okay, yes. I'm so happy to be here, and thank you for having me to talk about cardiovascular disparities and health equity, which typically we don't focus so much on. We're focusing on sort of the end game where we already have patients and we're taking care of them. But when you work with individuals who have multiple disparities, oftentimes we want to get to prevention and sort of, get to the baby before it's thrown out in the bath water, so to speak. So that's one issue. But the other thing is that typically it's almost taken for granted that what happens to people just happens to people when you recognize that there are issues or concerns that can be addressed simply because of who one is or where they live. Then you can really be very comfortable that you're taking care of the entire person or patient. So I hope to discuss with you today some of those issues. I have no disclosures relative to the discussion. And so we'll talk about the importance of cardiovascular disparities or CVDD. I'm going to discuss about 4 studies that are sort of landmark studies that really focus a little bit on what's going on in this country in terms of disparities. We're going to talk about life expectancy and why is it different and why it shouldn't be, and then a couple pearls for achieving health equity. So again, in the United States of America, there's advanced therapies, treatment options. Everyone should have optimal treatment. And that's not what we're seeing. It's different among different populations. And so everyone should typically have equitable outcomes and treatment. So the other issue is that we have continued challenges because it's just, contributing to the increase of a very large group of individuals with chronic health issues and a huge, cost to the nation. So those are some of the real reasons that we should focus on cardiovascular disparities. Notwithstanding that here in the United States, the population is changing, right? We're becoming a more diverse population. And so being able to handle or deal with or address the issues that are related to individuals in a not so homogeneous population is important. So if you look from back in 2008, this was a slide that was created by one of my great colleagues, Dr. Yancey. And the population over a very short period of time, about 50 years, is really it's going to go through a very rapid change from a more homogeneous, mainly non-Hispanic white group to a very sort of more diverse population. So we were going to have to deal with all of these different concerns and issues within these populations. So let's talk about life expectancy here in New York City. And I give this talk in different locations, and it looks really different. But right here in New York City, depending on where you live, can add or take away 10 years of life. from you depending on where you were born. Isn't that interesting? So if you look at the different areas here, I don't know if you can see my slide, but this is a portion of Staten Island. Here, a portion in Brooklyn. Here, we're here. This is Manhattan, so we're really here. So if you look at, Central Harlem and Spanish Harlem, you see the blue. Also in the Bronx. And areas of Brooklyn. So you'll see that the dark blue, your life expectancy is about between 75 to 79, but in the areas that are very lighter, your life expectancy is, almost 10 years difference. The other thing is that when you look at the prevalence of heart disease by age and sex and ethnicity, and these three circles basically shows the prevalence of coronary heart disease in the first circle in people greater than 20 years old, prevalence of angina pectoris or chest discomfort defined by ischemia in the second circle, and then actually prevalence of myocardial infarction. This is in all individuals greater than 20 years. And then we have all the different groups basically outlined in the colors, as you could see, representing Black and white men and women, Black and white and Hispanic men and women, as well as Asian. So we're going to show you that even though white men have the highest prevalence of coronary heart disease, myocardial infarction, and actually angina, they don't have the lowest life expectancy. In fact, Black women have a prevalence of angina pectoris, which is similar to that of non-Hispanic white males. And Asian women have the lowest prevalence of heart disease, angina pectoris, and myocardial infarction in this study. But again, here they're lumping Asians into one group, but I'll show you later that depending on where you actually come from, it may be different. But that being said, the highest prevalence of having these risk factors and the events are in white men, but they do not have the lowest life expectancy. When you look at the lowest life expectancy, it's the Black individuals, Black male and Black women. That's a disparity. When you look at cardiovascular disease or heart disease and stroke statistics, again, separated here according to males and females, white, Black, Hispanic, Asian, Indian, and now this also includes American Indian, you'll see that the non-Hispanic Black males have the highest incidence of death, right, per 100,000, followed by everyone, other groups sort of in the 30%, almost doubling in the Black males and then also in the females as well. So again, even though the incidence and prevalence of the disease may be higher, it's being managed better and people being taken care of either for several reasons that I'll show you later. So this is a pearl, and I'll be giving pearls throughout. So when you hear about lower life expectancy, you may start thinking of other issues that's related to crime or other things like that. But in fact, 30% of the mortality difference between Black and white men is related to cardiovascular disease and Black and white women, and it's driven by disparities. Other groups also underrepresented. There are other factors that create this disproportionate burden of CVD, including older people, people with disabilities, and with a low household income. So we're going to talk about that. And that's a health disparity. That's the definition. Difference in health status, healthcare access, quality, and utilization based on social race, ethnicity, gender, education, income, or where you live. As we showed you before, where you live makes a difference on what your life expectancy might be. And also disability. And a health disparity is a fundamentally unfair practice, both in design and in policy. Now, this is a pearl from the American Heart Association that basically shows that we need to focus on some of the other issues that actually contribute to a higher risk of CAD. So I think we all focus on the issues in the right? The risk factors, typical risk factors, we know that. Having a previous CAD and the other risk factors of diabetes, hypertension, dyslipidemia, et cetera. And then we talk about okay, so they're not adherent to therapy. There may be depression, but what is the real issue? Well, over here on the left, the demographics and socioeconomic status are actually very, very important, including poor social support, poverty, and lack of healthcare access. Obviously, your age and male sex tend to be more dominant in terms of the risks of events. But this is actually coming right out of the American Heart Association guidelines. So now, we need to spend more time sort of thinking about that. I know we don't have time in clinic, but maybe there's a mechanism, and I'll talk about that later, where we can have the support. So right now, I just want to go through 4 sort of studies or clinical trials that really underscore the importance of what we're just talking about. The All of Us study is a study that actually comes out of the American Heart Association, looking at electronic health records, and they looked at the data of over 300,000 individuals. And prevalence of CVD, and it was defined by race, ethnicity, and age, disability, sexual orientation, and gender identity. Also, a lower household income, and those with less than a high school degree. So basically using the multivariate logistic regression estimates, and looking at 230,000 individuals had some sort of information on cardiovascular disease, and about 17,000 had actual CVD issues. When everything was adjusted by hypertension, all the risk factors here that we talked about, hypertension, lipids, diabetes, body mass index, and smoking, it indicated that, of course, we know the Black participants had a higher adjusted odds ratio of cardiovascular disease when compared to the white. So this is even with everyone defined by these, these components that they included. They also found that there were higher adjusted rates of CVD based on age, disability, and income. So that's what I just told you. And this is one of the studies that you can reference that will tell you about that. And then this is just a table showing you the demographics of the individuals. So they did include white, Asian, Hispanic, mixed race, and Black, and included people who were older as well. And then they looked at their high school, their education, whether they had a high school degree or not, and of course, separating into income. So this other study I wanted to kind of share, because this one looks at the American Indians, and we typically don't have a lot of information about American Indians, but this is a very important study that looked at, it's called the Strong Heart Study, and basically wanted to look at cardiovascular disease and risk factors. So they looked at 13 communities in Oklahoma, Arizona, South and North Dakota, and enrolled 4,500 individuals. So it was robust for both men and women, and they were aged 45 to 74. They were seen baseline before they had overt manifestations of cardiovascular disease, and followed over 4 years, with 88% of them remaining alive when they reanalyzed them. The primary clinical endpoints were incidence of myocardial infarction, stroke, heart failure, evidence of a new MI on EKG, or having actually had an intervention, CABG or angioplasty. What they did was they compared these individuals to 2 other studies, the Cardiovascular Heart Study and the ARIC, or the Atherosclerotic Risk in Communities Study. So the Cardiovascular Heart Study was basically a study looking at all comers, not necessarily separating them into the socioeconomic or the social determinants of health risk factors. But the ARIC study, which I'll tell you about later, looks at individuals and follow them over years that were taken from underserved, communities, and was enriched for Black patients. So when you looked at the CHS study, you don't see a difference or a higher outcome in issues of stroke with the Strong Heart Study. But when you compare cardiovascular disease with those individuals in the ARIC study, and I grant you, ARIC study were bad outcomes, which I'll show you. But when you look at those individuals in the Strong Heart Study here, represented in Black, they had a higher rate, almost doubling those individuals in the atherosclerotic risk in communities, or ARIC study. So what's going on? So when they look further at the risk factors and life expectancy of the American Indians, there was a very, very high incidence of diabetes. They were overweight and hypertension. So this was what was found in terms of the risk factors. And here, where they're comparing life expectancy with white individuals, you'll see that the American Indians here have a lower life expectancy in all groups and all areas compared with the white here. So right here, this is non-Hispanic whites, and these are American Indians. So wherever you look at, in fact, here in Washington, look at the life expectancy, 69 compared with 77. But when you look at all of the groups compared together, the life expectancy is about 70 compared with 77 with non-Hispanic whites for males, and 74 for women compared with 81. So a lower life expectancy, more comorbidities, and again, because of underlying risk factors underscored by, socioeconomic and other issues. This other study, the multi-ethnic study of atherosclerosis, or MESA, this looked at Black, white, Hispanic, and quote, Asian, but again, they were Chinese individuals, and I'm going to show you later that Asian is not a homogeneous group. But anyway, this is the study. They looked at individuals, initially, again, were free of heart disease, and they followed them over years. The study is still getting information from these individuals, but they took people from Baltimore, Forsyth County, Chicago, Los Angeles, Northern Manhattan, and the Bronx, right where we live, and Minnesota. And this is an NHLBI study. So basically, they looked at clinical markers or characteristics of cardiovascular disease and looked to progression. It was fairly good representation of women. Half of them were women. And then this was a breakdown of whites, Chinese, African-American, and Hispanics. So again, we don't have time to get into everything, but they were about average age about 55 to 60. And what stood out here was that the African-American group was much more likely to be hypertensive compared with all the other groups across the whole study. And then they looked at other things such as blood pressure, they looked at blood sugar, glucose, insulin resistance, body mass index. The thing that stood out to me was that compared with the Blacks and the whites, the Chinese and the Hispanics were more likely to have impaired glucose fasting and higher glucose in general than the other two groups. So again, everyone's not homogeneous, and this is a study that kind of followed people over time. And of course, you'll see that, and these individuals over time, as they're continuing, you're beginning to see that there are more outcomes relating to bad outcomes, some cardiovascular disease in these other groups compared with the white groups. So I just wanted to throw in a pearl about the Asian American groups, because again, it's not homogeneous. It's the fastest growing racial ethnic group in the United States, projected to reach nearly 34 million by 2050. I showed you that globe that, that showed how people are, the population is becoming more diverse. But there's 7 subgroups: Asian Indian, Chinese, Filipino, Korean, Japanese, Vietnamese, and others. And why is this important is because they're, the percent of deaths is a lot more issue in certain subgroups than others. So the Vietnamese have the lowest percentage of heart-related deaths compared with Asian, Indian, Hawaiian, Guamanian, and Filipino have the highest percentage of heart-related deaths. So, we should be focusing more on managing risk factors in everyone, but really focusing on certain groups that have risk factors. And again, this is surprising, but I wanted to share this. Looking at type 2 diabetes, that's a major risk factor. And this was a study in Northern California in 2 million people. So again, you would expect the Latino and African Americans to have the highest prevalence of diabetes and sugars. But no, when you actually look at it, it was the South Asian, Filipino, and Pacific Islanders that had a higher prevalence of diabetes, which is a cardiovascular risk equivalent compared with the other groups. And again, these looked at all of the Asian subgroups, and you'll see that some actually had a lower prevalence than the African Americans, Native Americans, and Latinos, such as the Koreans and Chinese and the Vietnamese. So again, you can't lump everyone into one category and say, these are, Asian patients, these are their risk factors for heart disease. I also want to show you again, this is, again, another surprising thing when we talk about BMI. And here we're looking at an African-American female compared with a Filipino female. And they're both about 60. The African-American is 62, the Filipino woman is 69. The African-American weighs 160 pounds, and the Filipino woman weighs 115 pounds. But you all know that visceral adipose tissue is associated with heart disease and metabolic syndrome. And when you look at the African-American woman, she actually has less visceral adipose tissue compared with the Filipino woman. So again, you can't just take a quick look and say, okay, well, this one's overweight and therefore they have an issue, and not really look at the bigger picture. So the visceral adipose percentage in the Filipino woman was actually 84 compared with 25 in the African-American woman. And why is that important? Because Filipino women are more likely to suffer from the metabolic syndrome when compared with other women, Caucasian and African-American women. And this is a slide that's actually presented by several major authorities, including World Health Organization and NCEP, where you see that the metabolic prevalence is higher in Filipino women compared with Caucasian and African-American women, despite the risk factors that we know. And this is another slide that shows, again, the visceral adipose tissue by waist girth with people with normal BMI, looking at African-Americans, Filipino, and Caucasian. So the Filipino represented by the yellow line, again, is above that of the African-American and Caucasian women. So again, just pearls for you to recognize that everything that you see is not what you think it is. So again, BMI fails to account for differences in certain Asian populations. And so a greater proportion of body fat may be related to active visceral deposits, which lead to metabolic syndrome. You've got to recognize that the accepted anthropometric measures, including waist circumference, waist to hip, and trunk to total height distribution, may be a better measure overall than just looking at weight. Another pearl, and I'll show you on the next slide, especially in the younger individuals, is that of the group, the South Asians or Asian Indians tend to have a higher calcium score than the other groups. So let's just look at that really quickly. Here you're going to see younger individuals that presents with increased cardiovascular incidence and higher risk of CAD versus whites with a higher prevalence of insulin resistance, metabolic syndrome, CRP, lipid disorders, lipoprotein A levels, and the CAC scores. So this is something that we got to recognize as our population is changing. What is it that we're looking for in these younger individuals, not just assuming they're young and there's an issue. Just some pearls with Hispanic Americans. So they have the risk factors, but a lot of studies have actually shown that the age-adjusted death rates is actually lower compared with other groups. So 121 per 100,000 for whites, highest in African Americans, 183 per 100,000, but only 84 per 100,000. So how do you explain this, right? So is it a lower rate of cardiovascular mortality, or is there something else going on? So there's something called the salmon phenomenon, where things may not be reported, or people, when they get very sick, they may either go back to their country or they may not actually come forward for whatever reason. And so it may be underreported. And in fact, newer studies really looking at people living here in the US and being able to calculate actually is able to demonstrate that the mortality is higher, again, in certain groups. And again, it's not a homogeneous group. I'll show you the risk factors actually may be more swayed in one direction than the other, depending on where, which Hispanic ethnicity you're in. But suffice it to say that, again, everything you see is not everything you know. Here at Mount Sinai, I know we look at everything and we're able to follow our patients, so we know what the risk factors are. But overall, in a lot of the studies, it was spurious in terms of underreporting deaths of Hispanics, and in this case, Mexican Americans. So I wanted to show you, and I'm going to take this off because I'm starting to get hot. This is a pearl. Again, you cannot, just like with the Asian subgroup, you can't lump everybody who's Hispanic into one group. And this one, this slide just shows you that actually you, when you compare different subgroups of Hispanics, Cuban, Central and South American, Mexican American, Puerto Rican, you'll see that the Puerto Rican and Mexican American groups had a higher prevalence of Type 2 diabetes, which is, again, is a cardiometabolic risk factor. It's a cardiac equivalent for heart attack. So you may tend to see a higher risk in these groups compared with the others. All right, this is the other study that I wanted to share, which, again, we mentioned earlier, but the atherosclerotic risk in community study looked at over 11,000 individuals. Again, they followed them over time and looked at the associations between socioeconomic status and how it reflects in subclinical myocardial damage. So there was a strong association between socioeconomic status and clinical manifestation of microvascular disease, such as hypertension and diabetes. And actually, when everything was risk stratified, it was more significant in Blacks compared with whites. So we know that in certain groups, socioeconomic issues may contribute to the presence and progression of chronic subclinical myocardial damage. Other relationships, such as macrovascular markers, lipids, coronary artery calcium, and carotid intermedial thickness, were not as much evident. There was a weaker relationship. But when they looked at people overall over the years and compared the Black men, white women, and Black women, there was an incident heart attack of fatal heart disease that was more common at every age. So if you look at the Black men here, you'll see starting at 35, they have a higher incidence of coronary heart disease and, in fact, sudden death compared with the other groups. And the lowest group right here in green is the white women. So again, differences starting very early in life and increasing over time when you compare these groups. Hypertension, I just want to share, is a pearl, which is an underlying issue among all groups. And this is very, very important here. It looks like a little busy slide, but basically here we're again comparing Blacks, whites, Hispanics, and Asians. And if you look at all the groups, the yellow is represented by African Americans in the middle, white in the orange, light blue in Hispanic, and darker blue in Asian. And you'll see when you look at awareness of hypertension-related issues and what they are, in fact, the African Americans may be a little bit more aware compared with the other groups. When you look at treatment, they're on treatment, and everyone's on treatment, with actually the Hispanics less likely to be on treatment. But when you look at the percentage of control, the lowest group of people who are controlled, everyone's not well controlled, but the lowest group, again here, the Black group. So hypertension, which is of maybe the most important modifiable risk factor, is an issue that is understated. And why is this a particular issue? Again, in certain groups, there are certain things that more stand out, but in Blacks, they have a higher average blood pressure, develop hypertension earlier in life, more likely to have non-fatal, fatal stroke, cardiovascular death. And when you look at dialysis centers, they're more likely to be the ones on in a dialysis machine. So again, important. But we're going to just now quickly turn to the social and structural determinants of health. We're looking at risk factors, we're looking at everything, but the devil is in the details. Here, the little doctor looking around trying to figure out what's wrong. The little cats are like, why is he looking at risk factors when the key lies in social determinants? I say that it's everything and you don't ignore social determinants, but I think most of the times we're focusing on why are people not getting better. We're not looking at what might actually be looking us straight in the eye. So this is actually in the guidelines from the American Heart Association, and you could look this up. And so they're actually showing that social determinants of health has a major, major importance in terms of, outcomes relating to heart disease. So the healthcare system, systemic racism, sexual orientation, social support. Again, we talked about education, health literacy, economic stability, your environment, culture, and language. So I just want to, put a little pearl here about health literacy because it's an issue, especially in our diverse, our changing population, where, actually it's shown about almost half of patients with hypertension or diabetes had inadequate health literacy. And of course, that leads to an issue. So really do not forget the importance of health literacy. I just want to quickly focus on this one this little phrase here, implicit bias, which, hopefully many of us in the audience, we recognize what implicit bias is, but sometimes we don't, right? We just assume that, someone doesn't understand, or they may look a certain way or whatever. Or they come from a certain place. So because of that, they're lumped into a category. So just be aware of that. These are thoughts or feelings that you may not be aware of, that you're actually feeling them, and you may be mistaken about someone. So, and then instead of being neutral when you see an individual patient, you may have a particular preference for or an aversion to a particular person or group of people. And then you have certain attitudes or stereotypes that we may not be aware of. So that's implicit bias, and that plays a major role sometimes in how we treat patients. There's actually a study, and actually it was presented in the New York Times several years ago, looking at actors who were about the same age, but they were from different ethnic groups, and they were presented to medical providers, and different treatment strategies were provided for those individuals just because of who they were, when they actually had the same underlying, issue, and they also were actually at the same socioeconomic status, but that was not asked. But because of how they look, different treatment approaches were made, and that's an example of implicit bias. But never mind all of that. We know that there are definitely barriers that are related both on the patient level, the physician level, and also the healthcare system. And just things like we just talked about those. We talked about health literacy, et cetera, but cultural beliefs, they think about certain side effects. They may be talking to their family members, and there's a lack of trust, or there may be pride. Then also lack of choices or access, right? Or lack of involvement in the treatment decision-making process because you assume they don't understand it. Well, then call someone who can actually be a part of the conversation. So these are some of the barriers that are patient-related. Of course, cost. Physician-related, you're prescribing a complex drug regimen. You've got to not talk down to, but talk with, to talk about, this is what I'm prescribing, this is what it sounds like, but this is actually what it does. So communication barriers are important, and talking about that and letting them know ahead of time what adverse effects may be. And then also, I'll show you when it's multiple physicians involved, somebody stopping the therapy and not telling the other person, the patient gets confused and doesn't take anything. And then we talk about implicit bias. But for the healthcare system, we all know we don't have enough time, right, in the clinic to see everyone. And certain people actually need more time. And the system should recognize, like, this particular person is going to need more time. So we have health information technology issues. And I put clinical trials in red. We don't have time to talk about it, but a lot of our recommendations and guidelines come from clinical trials that are underrepresented for certain groups. So, you're making inferences and making treatments plans based on this, but we have to spend more time. And as Mount Sinai gets more involved in clinical trials to ensure that we have a great representation that represents those pie charts that I showed you in the beginning. This is from the American Heart Association that tells you about treatment approaches that will ultimately, your goal would be to, reduce cardiac death, non-fatal ischemic events, disease progression, and symptoms. And there's this whole little, circular thing here that talks about, that I'll show you in the next two slides, simplify it. But interestingly, they're talking about what I just said. It has to be shared decision-making with the clinical care team and the patient to reduce those barriers. And you could see what all those issues are. But simply, the patient's the person that we need to connect with, okay? You're here, you're the healthcare provider, but you're dealing with all these other issues, right? The healthcare system, the family, the community. Recognize that the patient's in the middle. So you as a healthcare provider, what can you do, right? You have to advocate for your patients, all right? So you have to be a strong advocate. Positive repetition means repeating things over and over again, because even when you come to a clinical presentation or lecture, you're only retaining about 10%. So, if you keep on repeating to the patient, then it will help for them to get it. You have to include that team approach that the American Heart Association talked about. And I have a nurse practitioner, I have an AA, I make sure everybody's on the same page, but somehow you've got to involve these other teams and then talk about about just, good habits and understanding the cultural mix that they're in. So I wanted to leave enough time for questions, but I want to teach you that equity is not equality, right? Equity is a completely different thing. So equality is everybody's given the same treatment, right? Everybody's a little different, but they're given the same treatment. So in this case, everybody's trying to see over the fence, and being given the same treatment, the little guy cannot see over the fence, right? The big guy doesn't need the box, right? So here in equity, the little guy gets the 2 boxes, and and now everybody's able to see over the fence. The big guy doesn't need it. In reality, what happens is the little guy gets dug deeper into the hole because of all the issues we talked about before, and the big guy gets too many things that he doesn't need. In fact, it may be dangerous for him. If he falls from here, it's going to be a big issue. And so we want to, get to the point where there are no barriers. That's going to be a hard thing to achieve. But if we keep on working on all the things we talk about, then there'll be no barriers. But for now, at least hopefully in our practices, we are engaging in equity, which is the second little box here. So with that, I'm going to end, and maybe there are some questions. Thank you.
There's a question in the chat. Sure. There's a question in the chat. Are there differences between specific population groups in the U.S. and the same populations in their countries of origin?
Also, what's the difference? I'm sorry, what's the first part?
So are there differences between specific population groups that are in the U.S. and the same population back in their own country?
I think that's an excellent question. Because in certain countries, you're dealing with, and not so much anymore, but we would be talking about issues that affect, quote, third world countries and here in the US. And so a lot of times infectious diseases is really the main, issue of concern. But granted, heart disease is rising. However, in countries of origin, so if we look at the Caribbean, if we look at Africa, if we look at, the Asian continents, people tend to be more natural. They're eating things that are grown from their gardens or from, that are not as processed. They're walking everywhere. So they're getting the exercise, right? They may not have access, but at the beginning, they may have better management of physical activity and sometimes foods that they eat. But America is the Mecca, right? And so when people come to the United States and now there's all this access of foods, there's all this transportation, whatever, they're not walking. More often than not, a lot of people gain a lot of weight and they're eating foods that are ultra processed and are not great. So if they already have an underlying risk, for instance, using, let's say, someone who may have already baseline insulin resistance that runs sort of as a genetic thing, or elevated lipoprotein A, and now they come here and they're not eating well, they're eating westernized foods that are processed, those risk factors escalate and it becomes more of an issue. So that's why we're seeing younger, groups that have already, uncontrolled diabetes, elevated lipids, and earlier issues of, having atherosclerotic disease. So I think that, yes, there are issues in your country of origin, and some of it would be, not having some of the treatments that are available here in the US, but some of the risk factors are not going to be as overwhelming there because they're not eating poorly and they're exercising. Here in the US, even with having, access to care or whatever, the risk factors are going to get worse. And then sometimes what happens, whether they're immigrants who may have an issue with the immigration status or just not, feeling very comfortable about, approaching, certain, treatment options or whatever, they may not go in for, treatment options, and so you have an issue. So I think, you may have an underrepresentation in some groups we talk about. In other groups, they may want to go or see someone who looks like them where we don't have that. And I could talk about, healthcare providers who look like or understand where people come from that might be helpful. But I think the dynamics kind of shift when you come from a country and you come to the United States. And in fact, where you should be better protected, in some groups, they actually are now shifting from an issue of infection to heart disease, which is, of course, the leading cause of death. So I hope that answers the question. Any other questions or concerns?
I was thinking a little bit, Dr. Fergus, you were talking about Sinai's really increasing their clinical trials. So how do we get, I know you're really involved in the community, how do we get more people who are underrepresented into the clinical trials?
Right. So I talked about a patient barrier being a trust factor. And people don't want to think that they're being guinea pigs. You have to have as a primary provider, you have to have a great relationship with your patient. Oftentimes, I do clinical trials, but I also work with my colleagues who are doing clinical trials and want to enroll people. And if that group does not have a good conversation with them, they're not going to do it. But sometimes what happens, so first of all, the primary provider should be involved and should know about the trial. Like the other day, I had a patient call up and they're like, listen, they're trying to get me to do this MRI, which I did last year, and I don't know what they're doing. And so I didn't know that this patient was being recruited. I had already sent several patients over, but I didn't know this particular patient was being recruited. And that ended up being an issue. She ended up not getting involved. But if you could be an advocate for your patient, know what trials they're getting into, so that when they're going into other people's trials, you can support them. That's a good thing. The other thing is being able to understand culturally and speak the language. So, if you're trying to get people, if you could greet in a language, and when I was in Queens, I knew how to speak Mandarin, greet in Mandarin, Russian, French, and English, because just saying hello, the patients actually realize that you're really trying to connect with them. So whatever that is, understanding whatever cultural issue may be there, if there's a trust factor, just asking about it. What are your issues? What are your concerns? Sometimes they're afraid about, a side effect of a particular thing, and for certain groups, they may be more concerned about their weight or their sexual performance or their hair or something like that. So being able to talk to them and connect is great. I do a lot of outreach events in Central Harlem, so I'm a familiar face, but sometimes if you do an event like a health fair, whatever, and that's a good place to recruit because people can come up and talk to you. You're in the environment where they are, so they can ask questions. They feel comfortable because their family and friends are around. So connecting in that way is also another way of doing it. But right in your office when you're seeing the patient, a simple greeting in their language it will go a long way, okay? Any other questions? So now everybody here is not gonna engage in implicit bias, right? And sometimes, it's unconscious. It's like, oh my God, look, oh wait, let me just take a step backwards. But just recognize that you're treating the individual, but it's more than just giving medications or referring for a study or a test, okay? They have to be a partner in their care. And in order to be a partner, you have to make that, you're that connection. We all do it because sometimes I'll see a patient come in like, oh my God, I know this is going to be a rough visit. But try to kind of take a step, recognize that you're feeling that way and try to take a step back, all right? And just try to connect as best you can. And you'll see that, you'll have a better doctor-patient relationship, and hopefully that person will end up being adherent to their medications and getting more involved in their own care. All right.
Thank you, Dr. Fergus. That's great.
Thank you.
That was great.